Welcome everybody to our conversation this evening. I'm Maria Edelberg. I'm the Executive Director here at the Delaware County Intermediate Unit. Before we start off, I just want to put some context to our presentation this evening. We solicited feedback from many of our participants this evening. And what we've done with this feedback is we organized it into 7 categories. They are opening and keeping open schools, and also extracurricular activities, face coverings, social distancing and other safety and health protocols, health and safety, which will also include health and safety that's sports related, cleaning, disinfecting, sanitizing, and ventilation, transportation, and understanding metrics. Our program this evening is also being recorded. And after the presentation, the participants, anybody who has registered, will get an email with a link that you can view this program at another time as well. The format of our program this evening is Dr. Rubin and Dr. Coffin will provide some opening comments and thoughts. Then we're going to move into the question and answer component of the program, where Dr. Petrando and Dr. Rushi will help moderate. I just want to take a moment to introduce Dr. Mark Petrando, the superintendent of Garnet Valley School District, and Dr. Maureen Rushi, the superintendent of Haverford Township School District, and they were both instrumental in helping to prepare for this evening. Then we'll have closing remarks from our presenters, and then I'll do a closeout of the program. So that is a quick introduction and an overview of this evening. At this point, I want to introduce our key speakers tonight. First, we'll start with Dr. Rubin. Dr. Rubin is the Director of PolicyLab at Children's Hospital of Philadelphia and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Rubin is one of the lead investigators on PolicyLab's COVID-19 forecasting model, known as COVID Lab, Mapping COVID-19 in Your Community, which tracks the virus transmission and test positivity rates across all U.S. counties and projected case counts for 817 counties with active outbreaks. Dr. Rubin serves as the Director of Population Health Innovation at Children's Hospital of Philadelphia, supervising a team that develops and implements integrated solutions using clinical care and technology to more proactively identify and provide needed services to at-risk patients across primary and specialty care settings. Dr. Rubin has also been very instrumental with all of Delaware County school districts, as well as the Delaware County Intermediate Unit, in helping us with our reopening plans. His knowledge and his input have been really invaluable to our plans and us being able to begin to reopen successfully. Also with Dr. Rubin is Dr. Susan Coffin, who is a faculty member at PolicyLab and faculty member of Pediatrics, Infectious Disease, Epidemiology, and Antimicrobial Stewardship Research Group at the Center for Pediatric Clinical Effectiveness, and professor in Division of Infectious Disease at Children's Hospital of Philadelphia. Dr. Coffin is also an associate hospital epidemiologist after she served as CHOP's hospital epidemiologist and medical director of the Department of Infectious Prevention and Control for over 10 years. Additionally, she is the medical consultant in the Division of Disease Control of the Philadelphia Department of Public Health, where she is supporting the COVID-19 response for the city of Philadelphia. Also, Dr. Coffin has been really critical in guiding us as well. You'll see her knowledge has been also such a valuable resource for all of us here in Delaware County. So at this point, I am going to turn it over for first Dr. Rubin to say some introductory comments, and then Dr. Coffin, and then we'll move into the question and answer. Dr. Rubin?
Yeah, thank you. I just want to start out tonight. We did this this Q&A last week for the teachers and staff across Delaware County. We thought it was also important to offer for parents and caregivers across the region as well too. There's a lot of information out there. I think there's a lot. We just want to recognize the amount of anxiety that people have and understand it, and understand that getting our schools reopened safely, requires building trust with our families, with the teachers and the staff. We've got lots of older caregivers out there, lots of caregivers who may have, special health care needs or, underlying health conditions, as well as our teachers and staff, and trying to put together a plan that can get us back to reopening schools as quickly as possible and as safely as possible, because we understand that in-school and in-class instruction is superior to the virtual options. We understand that our hybrid options are in many ways, a compromise, try to get some kids back in school. We're often choosing between, bad or worse in this situation. But I think we're going to need the resolve for the next few months, or through this winter, because the vaccine's not going to arrive in time to really change the calculus, if our hope is to get as many kids back for in-school instruction as possible. Now, many people have heard that during the summer, we were advising a lot of school districts around the area to potentially pause for a couple weeks after Labor Day, because we knew kids were going back to college. Based on all the modeling that we're doing, what we were seeing around the country, kids were going back to college. Colleges were struggling with those initial outbreaks, including in our area, Temple, St. Joseph's, although Villanova has done better, which has been good for Lower Merion. But we're seeing it certainly now in Center County, with the outbreaks in Penn State. We also knew that a lot of vacationers would be returning. And we definitely saw some upticks related to both college outbreaks, but also related to vacationers returning along the Mid-Atlantic seaboard for a couple of weeks, as well as through the Midwest. But we also knew, based on our modeling, that as we entered this early fall weather pattern with people not traveling as much, that potentially a second window would open up. And similar to spring, that just having a couple extra weeks of patience might give us a little bit better opportunity at lower case incidence, or at least at confidently stable case incidence, to try to get our schools open, putting in place all those safety plans that Dr. Coffin is going to talk about in just a couple minutes, in a layered approach that would try to make it as safe as possible, so that we'd have as low a likelihood as possible in terms of transmission occurring in schools. Now, we put out some guidelines around that. We talked about, some people were shocked to see how low the rates were for just let's resume school as we all did, get everyone back to school all at once. They were fairly low thresholds that reflected the amount of disease activity we saw in Europe and in Southeast Asia, where they reopened their schools in the spring successfully. There were some schools that went a little bit higher, Denmark, Belgium, some of the, Israel, though Israel has been struggling with outbreaks in its schools, and even some of those European countries, as they started to come up recently at rates that were just a little bit above our thresholds, more like 15 to 20 cases per 100,000. We started to see outbreaks in Berlin because they took off the masks. And all this new information, we have to recognize this is a novel coronavirus, and all this information is informing where we put these thresholds to try to identify when was the window to reopen. Now, we provided a higher threshold at about 35 per 100,000, which was never meant to be absolute, that recognized for those places that were stabilizing at a little higher rate than just the schools in Asia, or in Southeast Asia, or in Europe, that you could start, if you had strong mitigation plans, if you felt comfortable with the size of your campuses and your enrollment, that you could start by prioritizing the kids, getting them back for in-school instruction, particularly the elementary school kids, the kids in special education, kids we knew who were going to have a harder time learning virtually. We had a lot of parents in the workforce. Trying to get as many of those younger kids back is a little bit easier. It's not perfect, but to build some confidence around your safety strategies and bring kids in incrementally, starting with your elementary school kids and special ed kids, and then moving up to the middle and high school ages, and trying to take this window between now and maybe early mid-October, when we think that weather's going to be more temperate, and hopefully we get a long enough window to get as many kids back in school as possible and build confidence around our thresholds. There were a couple things that I think informed us to be a little, people have said to me, well, we're at 50. Why, you said 35? And this is where I say, there's a range of uncertainty between 35 and 50. And one of the things that helped us that this summer was some reports out of the children's hospitals that actually allowed us to take those weekly incidence rates and translate them into what we think the number of students and staff will be on day one who are COVID positive entering a school. And that's because all these children's hospitals, before their elective procedures over the last 6 months, have been testing kids as a prerequisite to allowing surgeries to proceed. And that's now allowed us to fairly confidently say, alongside some data on some schools that have done some testing, that if you're at, let's say, where Delaware County has mostly been at, 50 per 100,000 per week, if you multiply that by 10, that's a prevalence rate of about 0.5%. And that seems to be around the right territory in terms of understanding if you had a school of 1,000 kids, that you may have about 5 kids, give or take a few on either side. I've seen lower, I've seen a little bit higher, maybe a couple staff members on day one who may be positive and asymptomatic. Now we have to ask ourselves in those rates, whether it's 35 per 100,000, which would be 3 to 4 kids, or 50, which would be 5 or 6 kids, or 70, whether it would be 7 or 8, as long as it was stable, right? Can our safety protocols, the ones that Dr. Coffin are going to describe, will they be sufficient if kids are masked, if we're following symptoms closely, if people are keeping sick kids home every day? Will that be sufficient to protect us against outbreaks in the school? Because we're never going to have a situation where there'll be no kids. We know that now. We just need to have it low enough that they can't break through with an outbreak because we have multiple layers of our interventions. I also want to remind people there were a couple other things that we saw this summer, and we've seen it now in a couple of different sort of anecdotal studies, which I think have been the most powerful this summer. One that I just heard about in a private school in the region, actually. The first was an outbreak that occurred in a barber shop or a salon down in Missouri. This was way back in April or May when they started reopening in Missouri. There were 2 salonists who were symptomatic and COVID positive in that salon. They treated 140 clients, probably on length for at least 45 minutes for each of those clients, within 3 feet. Everyone was wearing masks, and none of those people got infected. That was really important data for our teachers, I thought, because they're the ones that are going to be hands-on with some of our kids, particularly our younger kids, and to have that confidence. And more recently, during a orientation for the teachers and staff at a private school in the region, 1 out of 200 of the faculty and staff tested positive and became symptomatic shortly after the week. Yeah, this was the week before school. Everyone was wearing masks and distanced. Everyone was tested, and not a single person in that school became positive outside that individual. So those things kind of give us confidence that with the limiting the amount of incidents that we have going into the school year, combined with good safety approaches, we can actually do this. But it's going to take a commitment at our community levels, and every community has to judge for itself the strength of its mitigation plans, the buy-in of the parents and the families in terms of how they go about the routines in those counties in terms of trying to protect each other. But there is a route to safely reopening, and that's what we're here to talk to you about today. And the last thing I'll say before I hand it off to Dr. Coffin is to remember when we went back to work in March and April, and I'm not just talking about the doctors, but I'm talking about my nursing staff, our office staff. They were terrified. We were terrified. We didn't know what this meant. And Dr. Coffin was among a number of individuals in our hospital that put together what I thought were terrific safety plans, how we were going to distance in the office, how we were going to move our families through by not allowing them to infect each other. And we have created an environment at CHOP where we have not seen transmission to our staff, and we are actively treating COVID positive children and families. And I can tell you a couple, part of the fear of moving on is the fear of getting over that threshold the first time. But what builds confidence is seeing these plans work and be put into place. If you're in a place where you don't think that people are attending to the plan, that is a different question that needs to be raised with your district. But in the simple your plans, you start to build confidence to the point now that I feel safer at work with those COVID positive patients coming in that I know about than walking through a market in my neighborhood or in the Delaware County or Montgomery County region. And that's where we have to get to as we think about reopening schools, and I think we can. So I'm going to turn it over to Dr. Coffin, and then we'll go into the Q&A.
Hi, everyone. It's nice to be able to talk with you and share our perspectives and what we've been learning over the past 6 months as we care for children, both in the hospital and clinic setting, as well as consider all the challenges that children and families are having throughout the communities around us. I think one thing which has really plagued many of our discussions about how to keep safe have really been, how is this virus, related to the question, how is this virus transmitted? And for those of you who followed the news closely over this weekend, you may have caught wind of yet another bump in the controversy about how it's transmitted. But I'd like to share with you my perspective and my observations. I hope you'll find that it's fairly convincing that we know a lot about how this virus is transmitted, and we know a lot about how to successfully prevent spread. And so it's on that I'd like to go forward. So from the start, we've known that this is a virus that is spread primarily through respiratory droplets. And what that means is when we talk, when we sing, when we laugh, we are at risk of sending our respiratory droplets out into the world, and those respiratory droplets could land on someone who is susceptible for this virus. 100% of us were in March, and cause an infection in them. However, we know a lot from all sorts of different viruses about how to stop respiratory droplet transmission, and that's through mask use. This is something we've been doing for decades in hospitals and in other healthcare settings to stop viruses very similar to the coronavirus from spreading through droplets. We know that this works based on what Dr. Rubin just described to you, seeing, I'm sure, dozens of children with coronavirus, masked but safe. I know as a personal tell, I hope you don't mind, Dr. Rubin, you've never gotten coronavirus, correct?
Not sure.
Well,
but it was nothing related to this to any
to
of the
work exposures. Okay.
Exposures, yeah.
So I think my point is that most of my colleagues, myself included, have never contracted coronavirus because our protocols work very, very well. Masking is the centerpiece of it. Masking catches droplets before they leave your mouth and provides a second level of barrier to the person who's standing across from you in when you're having a conversation. So 2 barriers are present in that. Another essential part of preventing transmission is just growing the space between 2 people. We know that respiratory droplets fall because they have gravitational force pulling them down. They're large enough, and they typically don't travel longer than 6 feet. We also know that there's certain circumstances under which we can have enough force with the way we're speaking, singing, playing a trumpet, that could send a respiratory droplet further than 6 feet. And that may give rise to some of the buzz that you've been hearing about. Could respiratory droplets or could transmission happen even if we are further than 6 feet apart? And the answer there is, under certain select circumstances, maybe. However, we don't rely just on distancing. In addition to masking and distancing, we have the critical piece that, coupled with low virus rates, are really good surveillance and screening protocols. We don't want anybody to come into our schools or our other community settings if they have any symptoms or if they've recently been exposed, because we know that they may be infectious. Taking care of the environment is another key part. We've had a lot of discussion over time about what exactly does that mean. People have debated a lot. Does it matter how frequently we clean our hands? And the answer is probably yes, but not as much as it matters how consistently you wear your mask, how carefully you adhere to 6 feet distancing. And then finally, the physical environment around us. The surfaces of the tables and desks in our area can and have been places where we can recover infectious coronavirus after somebody who's been very sick has sat there unmasked. And so that makes good sense to keep the surfaces that are going to be shared by multiple people as clean as possible. Last, we've talked a lot, and there's been a ton of attention in the press to this question of, could this virus be spread through air currents and for long distances through aerosols? And I think we actually, can say a lot that supports the idea that this does not happen commonly. And in fact, it happens so rarely that we really struggle to find good examples. What you probably have heard is time and time again, the example of the chorus practice in Washington, the couple sitting in front of the air conditioner in China. The reasons we're hearing those scenarios over and over again is that's where the evidence is. What we also know is that aerosol transmission isn't happening when we're wearing our masks and we're staying 6 feet apart. We know that because of all of the doctors and nurses and all of the other essential workers who have gotten through this with relatively low rates of getting infected through their workplace. And then last, I feel we really get good evidence that this is not an aerosol transmission virus, or at least not commonly at all, by the fact that people can live in the same household together under stay-at-home conditions. So they're together 24/7. And if you put one person into a house who's got coronavirus and they live there for a week, how many people come out the next week with infection? And the answer there is 1 out of 1 out of 8. So 15% of people who are exposed in their house to a member of their household will get infected, not observing any of these prevention protocols. So I think that is really compelling evidence to someone like me who has studied airborne transmission and knows that if we put somebody with measles into that household, 100% of people would get infected. Same thing for chickenpox. So we know that what it looks like to have an aerosol-borne infection enter into a household. And this is not what we're seeing with coronavirus. So to kind of sum up things, I think we have really good knowledge about what needs to happen in our communities to propel us forward and be able to reopen group education, in-person education. And again, great screening before people come into the door, consistent use of masks, following the distancing recommendations, and keeping hands in the environment around us clean. And so with that, I'll pause and turn it back over to Maria and the team for questions.
Dr. Petrando, would you like to get us started, please?
Sure. Thank you, Dr. Edelberg. And before I get started, I'd like to thank the Delaware County Intermediate Unit for arranging this event. The teachers who attended last week's meeting thought the information was extremely valuable. I've received many, many messages of support and folks expressing the fact that after the meeting, they felt more confident and comfortable coming back to work. And I'm sure that the parents are going to feel the same way this evening. Dr. Rubin, Dr. Coffin, it's great to see you again. And we'll get started with some of our questions. Dr. Rubin, I think this question's for you. You were clear that you believe it's now safe to reopen schools. But in terms of the instructional delivery model, what strategy do you think's best? Should, obviously we're in virtual now. We have an opportunity to go to hybrid learning and then full in-person learning. Can you talk a little bit about how schools perhaps should phase in students?
Well, certainly, if you want to take an incremental approach, I think it makes sense to bring the younger kids back first. There's a lower risk of infection, at least symptomatic infection in the younger children. We think that is held. There's a lower risk of transmission from the younger kids to adults as well. Some of that may be height related. Some of that may be because they're less symptomatic as well too. So we do recommend, if you want to confidently start, you can start getting your younger kids back. They don't learn well virtually. and then follow that within a couple of weeks with your middle school and your high schools. Now, the hybrid plans, you got to remember, the hybrid plans are really about a compromise which says we can't de-densify our classrooms or our hallways because of the facilities we're in. If you're in a smaller school district or you have a very large school and you can de-densify, then you don't necessarily need to do a hybrid plan, but we can't have classrooms with 25 or 30 kids packed into a classroom. It's just not safe enough for the kids, their families, and the teachers, knowing what we're going into. And one of the things I didn't mention is we're going into it's going to be harder in the winter. That's why these protocols are going to be so important. And so, whatever you see now or thought you saw over the summer, right, is nothing compared to when we go into flu season. And a good reminder for everyone to get their flu vaccines this year. This is not a year to skip the flu vaccine. But if we do our protocols, we should see flu rates come down. We should see other respiratory viruses come down, making our protocols work even better. But I would say, the hybrid plan is great to achieve less density. Having 10 or 12 kids in a classroom spread out with at least 6 feet, I think that's critically important. We have never embraced WHO recommendations of 3 feet. As Dr. Coffin has mentioned, our knowledge about larger respiratory droplets, which is the primary mode of spread of this virus, most of those will settle out within 6 feet. And so the combination of masks and 6 feet and avoiding 15 minutes of exposure within 6 feet, if I were to tell you, that's 90% of your advantage. And then you got your hygiene as well and keeping sick kids out of the classroom. There are so many layers here that, to me, this is the multi-layered public health intervention. We know it's not going to be perfect. There are going to be times when a kid pulls off their mask, or the younger ones will run around with each other outside and you'll say, look, they can't do the protocol. We know that, that each layer is not going to be perfect, but you would have to fail on all the layers to get an outbreak within the school. And so it starts with that lower transmission. Then you got the masks and you got the distancing and you got the hybrid, you're keeping kids de-densified throughout the day. You're not allowing kids into the school. You're relying on the trust of parents and families to keep kids home. This is not the year that we're going to have colds coming to school. And so I think there's a lot of layers here that should add confidence in terms of the protocols, and hybrid plans are one of those if you can't achieve the physical distancing of kids in the classroom.
Then the next question, as you know, Dr. Rubin, extracurricular programs are a vital component of students' overall education, especially when it comes to social and emotional wellness. What are your thoughts on reinstituting our extracurricular programs, namely athletics and other clubs?
Now, we've actually been out ahead of this. We worked with our sports medicine department. If people, go in and look at our website, we have developed plans with Dr. Coffin, the infection control team, that recognize this is all about moments of transmission. And just because we may have to do distance learning, early on in the year, or hybrid plans, doesn't mean we can't have activities. It's not like when we decide to go to distance learning that we put locks on the doors. I've heard some really creative plans where some kids who were not learning virtually well could come in and actually get in-school instruction, a handful of kids, even as most kids learn virtually during periods, because it's just making compromise. This is about de-densifying, reducing the moments of transmission, and you shouldn't have to penalize let's say a tennis team, right? Or a track team. There are low contact sports that can operate very, very safely. There are medium contact sports that during lower rates of transmission with some mitigation, like softball and baseball and even soccer, that can operate, or volleyball, if people are thinking about the moments of transmission, using masks appropriately when they can. And then there are really high contact sports, like football or ice hockey, right? Or wrestling, which unfortunately it's very hard to return to team competition unless you have extremely low rates. We have seen enough outbreaks through football teams, ice hockey, to know that if you're going to pursue that avenue, and this isn't just about scholastic sports, this is about your youth sports leagues, regardless of the decisions of PIAAA, I would feel safer with a child. And I used to be a youth sports coach. Particularly in the high contact sports, if they're going to proceed with some level of competition, on a frequent basis, just like we're seeing the other sports leagues to do it. So it's going to be very hard given the resources we have to get some of those sports going. But I think there's a lot of opportunity for activities. And I wouldn't stop at sports. It could be Model UN. It could be another, I want to think about our academic activities here as much as we think about our sports, and recognize that, we can, the school, the campus is going to look a lot different this year, but, activities were always a part of that, whether we were doing distance learning or not.
Thank you. Dr. Rushi?
Dr. Rushi, you're on mute.
Thank you. Thanks, Dr. Bertrando. We have a few questions that came in about face coverings, so I will direct some of those that I have summarized to you, Dr. Coffin. Can you talk about the face shields? Do you recommend a particular type of mask when children are going to be indoors? And how about children who have a hearing loss and need to be able to, read lips? Or might be listening to a muffled voice under a mask?
Sure. Why don't we start with the general circumstances and questions around what are characteristics of the most effective masks. And what we've learned both from experimental studies as well as from observation is that masks that work well typically have multiple layers. They typically have a relative tight fit across the bridge of the nose and the top of the cheeks. And they typically come down and also have a bit of a fit underneath the chin. And that's just simple mechanics. We want to catch respiratory droplets and we want them to stay contained within that mask. So masks that can achieve that can be made of cloth, but we would want them to be multi-layer. If they're going to be made of cloth, they should also have a relatively tight weave. Think of your sheet thread count. And if they're going to be more medical masks, there are plenty of the typical medical surgical masks that work very, very well. They're what I've relied on, what Dr. Rubin has relied on for the past 6 to 7 months. And it is not necessary for people to use what they may have learned to refer to as N95 masks. Those are useful in very particular medical settings and not a part of prevention in a community setting because the risk just isn't there. So that's kind of the general framework around masks. Early on, a lot of creativity was spawned and people came up with some really innovative ways to deal with one of the most vexing problems of masks in education, which is reducing the amount of facial expression that a teacher or a student can put out. As well as providing the opportunity for people who are learning language or have hearing loss to actually watch word formation. And so there are a couple of masks. One is an origami type mask made of a very flexible plastic film. Another is a conventional mask into which a clear panel has been inserted, all for the goal of increasing visibility of the wearer's mouth and facial expressions. I know that our audiology and hearing team at CHOP were very quick to find these and use them, and they love them and swear by them. So I definitely encourage people to pursue that. The last part of the question was around face shields. And face shields, I think, have a couple of great attributes. One is they protect the eyes. We know the eyes are a place where if virus was coming at you or you rubbed your eye and had virus on your hands, you could get infected. So they're nice in that they provide that sort of extra protection. But the thing they don't do is provide much of a seal around the sides and bottom. And so that is a vulnerability that I think if all things are equal, I'd recommend people not choose a face shield. Certain circumstances, they can be very useful though, or when people can't tolerate a mask. And then I think a face shield is a good compromise rather than nothing.
I think a couple of things I would add, just number one, the gaiters and the bandanas, I'm not a big fan. The gaiters, if anyone's ever put on a gaiter, they're like, they're pretty, they're pretty easy to kind of breathe through. And so I'm not sure they're blocking very much. And I think some studies have borne that out. I think the bandanas, you can breathe underneath them. I think the surgical masks, they're pretty cheap right now. They're widely available. They've got that sort of wire bridge that Dr. Coffin talked about. Really important. I think sometimes you should prepare yourself that when the teachers have to do some hands-on, particularly in our special ed classrooms, they may double up the face mask and the surgical mask to give them a little bit of added protection, or wear goggles. There's some clear goggles that work pretty well for eye protection. Glasses are certainly, for those kids who wear glasses, confer some protection, but the wraparound goggles are probably a little bit better. So, there's some other strategies, but, the face masks that Dr. Coffin described are the ones that we tend to prefer.
Great. What's your opinion around children who suffer from asthma? Should those children be required to wear a mask? And if not, how safe is it for all students and staff to be in a classroom with children who cannot, for whatever reason, wear face coverings?
So I'd like to just make a comment about what is a common misconception, which is people with any sort of breathing difficulty cannot wear a mask. There are many masks that are highly breathable. You may have to play around and try a couple to get one that you are comfortable in. But asthma is not a contraindication to wearing a mask. And I would strongly encourage parents of children with asthma to remember this is an awesome time to make sure that your child's asthma is under tip-top control for a whole bunch of reasons. But one is so they can comfortably wear a mask and keep themselves and others protected. And so I would strongly encourage people not to consider a pre-existing condition a contraindication to using masks.
Can I tell you, I was also on a town hall at CHOP with Dr. Spergel, who is one of our best allergists. We have a lot of good allergists at CHOP, and and the asthma rates have plummeted since kids started wearing masks, particularly our kids with asthma. It's both the pollen and the infections. It's both. And so, this is the season. He joked that if, we should get rid of all the medication, just put masks on all our kids with asthma because it's like 100% effective. So for our parents with asthma, I think our kids can handle it. And I think it's going to make them healthier through this school year. They're going to miss fewer days of school.
Okay. And the last topic on face coverings has to deal with the idea of either mask breaks, or, do you think there is a time when students are in school, whether it's half of the day or the entire school day, that they should be able to take their masks off?
So, clearly, as we've been sharing with you, we think masks are one of the most important prevention strategies to have. And so the concept of mask breaks needs to be put into that context. Mask breaks, if needed, should be short and highly controlled to prevent anyone without their mask on being less than 6 feet away from another person. So my recommendation is to consider at least one mask break during the day, which is when people sit down to have their lunch. But to remind people that you can have your mask on during lunch period, you just can't have it on while you're actively having your sandwich or drinking your water. And so a 20-minute mask break for a 20-minute lunch period is completely unnecessary. Most kids are going to consume their lunch in about 5 minutes. And so 5 minutes is the proper length of a mask break for that type of a lunch. And I think we as adults actually need to remember that too, whether it's within the school setting or within an increasingly active social life. If you're meeting somebody for a cup of coffee, just remember that that's a moment when masks are off, that transmission is at its highest. And so we need to be on guard and put in all of those other protections for that moment.
Thank you. I'll turn it over to Dr. Bertrando now to talk about social distancing.
Dr. Coffin, so there's so much importance being placed on masks that some parents are wondering, well, if masks are so effective, why do we have to be in virtual learning? Why do we have to maintain 6 feet of social distancing?
Sure, that's a great question. And this really gets at the kernel of public health, which is, as Dr. Rubin explained, a layering of strategies. None of these things are going to be 100%, both because adherence 100% of the time is going to be very challenging, as well as the fact that some of these strategies, we can think of scenarios when there might be a breach. And so therefore we rely on just stacking up multiple strategies. And the one thing I always remind people of, it's not a question of distancing or masks, it's distancing and masks. And so it's not as though we can choose one from column A and one from column B. We have to do them both. And so in a school setting where kids are moving, adults are moving around, we can't rely on people always being 6 feet apart, let's say when they pass in the hall. So we have to be pretty strict about mask wearing.
Can I also add, we've been modeling those 820 counties since March. We watched those masking mandates go into effect, and we also had a paper out in the late spring. Physical distancing is the #1 intervention. The masking has allowed us to return to the classroom, but not in the absence of physical distancing. I mean, that's why we have stood behind the 6-foot recommendation. There is nothing that is as effective as physical distancing, but obviously we can't live in our homes forever. We have to accommodate to this risk, and the masking allows us to accommodate to a risk, to go back to a restaurant at limited capacity and sit down and in our moments of transition, wear that mask to the chair, to watch our waiting staff who are all wearing those masks, to even keep our mask on when that waiting staff comes over the table. All of the above. And so, so I just wanted to echo those comments that don't underestimate the value of the physical distancing and the de-densification of our hallways and our classrooms.
So there has been no movement away from the 6 feet of social distancing. That
never moved off of that chop. We never bought into those. WHO recommendations did not make sense. And I think that, parents and teachers are going to know when we're cutting corners. And to us, that's just trying to cut corners in the face of the evidence around respiratory droplets.
So to that end, one of the issues that we're facing, all school districts are facing, is lunchtime. How do you have groups of students safely eat lunch and still maintain social distancing and masking?
I think lunch is going to have to look different this year as compared to the start of the school year last year. Lunch has to be a highly controlled time because it's going to be a high risk time. It can't be the time for socializing, for allowing kids to blow off some steam. And it can't be a time for the adult staff, whether it's the teachers or aides, to let their guard down, because the kids are going to need coaching, as we all do when we get into common situations that you tend to forget about doing your prevention practices. So I think really figuring out a strategy, whether it's having kids eat at their desks and be pretty mindful that kids can't be turning around while they're eating with their masks off to go chat with their buddy who's sitting right behind them. Some places have taken to using plexiglass barriers, particularly at lunchtime. That may not be something that's feasible in a large, busy school district. But that is something that's worked. And then alternatively, trying to bring kids into a cafeteria setting with a similar kind of de-densifying approach, making sure that kids are spaced far apart, coming up with strategies to enforce that so that we don't have, 2 kids, scooting along a bench all of a sudden to sit right close next to each other. So I think the distancing and controlled behaviors are really going to be key for keeping lunches safe.
How about other large gathering activities, for instance, at the elementary school with recess?
Recess has been a time where, because recess is typically conducted outdoors, we have all hoped that time outdoors would be safer than time indoors. And I think that is generally true. However, it's still of value to wear a mask and to be 6 feet apart, whether you're indoors or outdoors. And so to the extent that children can be engaged in activities during recess that keep them from clumping up together, you may consider a mask break there. But I think it's going to take a lot of supervision and creativity to make that happen, and to have kids change their behavior on a playground.
It was a good story that one of our colleagues who couldn't join us tonight,
Yeah.
Dr. Meredith Matone. We're getting a lot of experience. I think one of the things in terms of taking this window to build confidence around your safety plans, particularly before we get into some potentially higher transmission rates later in the fall, is that teachers are extremely creative, staff is really extremely creative, and are understanding this multi-layered approach. And so one of the observations in some of the classrooms in the area was that the younger kids couldn't maintain 6 feet distancing. And so elementary school teachers have done stuff to operate in smaller cohorts. Maybe they partition the class into 4 groups, and they try to maintain smaller micro cohorts within the class. But instead they decided to move a lot of the kids and spend more time outdoors with the younger kids, because they had a harder time of maintaining the distancing in the class. But then, they traded that off by adding the masks back outdoors as the kids played. And that's what we mean by a layered approach. That as you give on one intervention, you layer up on another one. And, and you may actually layer up as, if incidence rates start to climb as the year goes on, we might have fewer masking breaks, right? We may go from full instruction back down to hybrid. There may be times of the year we have to go back to distance learning to say we got to cool it off for a couple of weeks. And so, so I think this is what we imagine with a layered approach that has multiple types of interventions that are going to help reduce the likelihood of an outbreak within the school.
Thank you. Dr. Rushi?
Thank you. Our next topic is health and safety. And as you can imagine, we've got quite a few questions here. I tried to group some together. How will a school know if it is safe for my child who has seasonal allergies to be in school? How will a school distinguish between the children who are sick with possible COVID or have flu-like symptoms, a cold, or allergies?
I think this is a great example of where a real partnership between the parent and school is essential. The school is not going to know when someone walks in with a stuffy nose and a new cough, that isn't a sign of COVID. And that school, if left to their own devices, would and should turn that child around and say, we gotta, ask you to leave until we sort things out. However, as a parent, if these are your child's typical allergy seasons, there have been no exposures, and you've been quite good about social distancing and limiting your household exposures, you could, consider saying this is likely a flare of seasonal allergies, particularly because, my kid didn't take their medicines last week. But I would work with your child's clinician, nurse practitioner, or doctor to determine whether or not it is sufficiently safe to say, yep, this is seasonal allergies, or if it's important, given all of the circumstances around your child and in the community at that moment, to get a COVID test.
And I think, someone who's a primary care doc as well, I see a lot of allergies. They're very different than fever, chills, and a cough, and a kid who's coming down with something. And I think parents understand that too, and the symptoms that we're looking for. I will again emphasize the use of the masks. It's just so impressed from our allergists talking about the reduction in allergies and asthma. Asthma also apparently has a biologic advantage because they tend to have fewer what's called ACE receptors, and so we've actually seen less severe disease, COVID disease, in people with asthma. It's been sort of one of the strange exceptions in the COVID epidemic. But I think, here's the paradox. I mean, or here's the challenge. If people are wearing their masks, you're going to see less allergies. You're going to see less flu. You're going to see less other respiratory viruses, and the protocols build on each other. If we have problems with compliance, you're going to have more seasonal allergies. You're going to have more other respiratory viruses. You're going to have bigger flu outbreaks. And then suddenly you're going to be removing kids and more kids from school, to the point that we're going to have to revert to distance learning. So to me, the strength of this comes from the multi-layered approach and from active sort of enforcement and buy-in by the community as we try to get our schools open. The two major risk periods that we identify are school. I'm sorry, our lunch. Lunchtime is going to be a big one. And I would think some degree youth sports, and making sure that we have established protocols that we list on our website around when to use individual drills and when it's actually safe to scrimmage. But besides that, if people follow these protocols, I think we're most likely to do well. And if the assumptions change, we may have to pivot and just prepare for that as we go through this year.
And Dr. Rubin, for that child who was feeling fine, left home in the morning, and then exhibited symptoms during the school day, what recommendations do you have with respect to the child's siblings, the other children in the classroom, the teacher as well?
So let's talk about sort of how we're going to make decisions. I mean, to actually close the class or the school, you remember I started out by saying, if we stayed at 50 per 100,000, we're going to have 5 kids every week who have it, right? If we got lower, it would be less. And so, those 5, so you can imagine there are going to be kids who are pulled from the class who become symptomatic throughout the year. But if they are distanced and they are wearing their mask, that's great. Now, their siblings, while that kid is sick and getting tested, I think it's appropriate to keep the siblings home from school until we have more information. They're a household contact as we're trying to gather information on a symptomatic kid. If that kid is found to have another virus and those kids remain asymptomatic and the parents are removing, then the other kids can return to school. In general, I might expect that kids sitting right around that kid in the classroom might be asked to quarantine or revert to distance learning for a period of time, just to kind of monitor their symptoms, making sure they're not becoming symptomatic. But we're not going to close down classrooms if there's a kid with COVID this year. The only time we're going to talk about closing classrooms, I think, is when there are cases that are linked within the school. So a kid gets sick in the classroom and then another kid gets sick who was one of the exposures, and it was a clear school linked related transmission. I think that's what we're likely to be looking at here, but we'll have the occasional kids who are removed and a couple kids who are asked to kind of quarantine. But that should be the normal. But we should not anticipate multiple kids, 5 kids in the class get COVID, in which case then we're going to likely have to kind of hit pause, and whether in the classroom or the school. And that's what we're trying to avoid. I sort of said in the beginning, it's easy to open schools. One of the reasons we waited till the 3rd week of September was, once you get them open, what you're trying to do is put protocols in place that are going to prevent the likelihood that you have linked transmission in the school, which is going to end up just closing you down again. And so we're confident now in watching some of the elementary schools having done this, watching some of the other schools that are doing it in areas with less transmission, that it can be done well while protecting particularly those who are most at risk, the caregivers and the staff in the school.
And so I'd just like to add on that the one kind of critical ingredient in all of this is going to be a really strong partner with your health department. And for you folks, it'll be with Chester. And I think knowing each of your schools, knowing who you'll be talking to in the health department, because that's going to happen. You're going to get to know that person very well, and to start building that relationship now and understanding how the Chester County Health Department is going to guide you. There's a lot of different ways to approach addressing a single case in a school or any group. But you definitely want to be in quick and close partnership with your health department, because there's oftentimes a cascade of questions and investigations that have to happen.
If that child who was sent home because they exhibited symptoms was tested a day or so after they were home, the parent was able to get them testing and the test results came back negative, should that child be able to return to school immediately, or do they still need to stay home, need to quarantine in any way?
In the scenario you described, when a child is ill, gets a test, and is found to be COVID negative, that's a scenario when that the child could return to school as soon as they're truly better. So that's a scenario where we revert to a typical ill absence. So when the child is really better, afebrile, off of Tylenol, getting back to their normal activities, then it's time for that child to return to school.
And it would be preferable if that, with the relief of the respiratory symptoms as well too. So resolution of symptoms is what you're looking for, and then returning the kid to school.
Great, thank you. We also had some questions about mental health. What supports do you think should be put in place to support social and emotional well-being of the children? For example, teachers could become ill, teachers could be hospitalized and die. What discussions should we begin to have with our children who may see their friends or teachers become sick, hospitalized, or perhaps even die?
Or even their family members, right? So it's, I think it's extremely important. And one of the reasons we wanted to maintain activities was recognizing the socio-emotional challenges that we're having here in terms of how much isolation the kids have gone through in the last 6 months. But I would encourage our districts to really think about the mental health issues, to actually infuse that into some of the way they think about their curriculum, and talking to the kids, encouraging the kids to talk about it, but also ensuring that you have good connections to resources within your communities, or potentially bringing those on site when needed, if that's at all possible. And then speaking to your pediatricians, I mean, so if you are a family out there, reach out to your clinicians, to your pediatricians. We encourage our families to come in the office. We're doing a lot of behavioral health integration through our primary care teams at CHOP, but to really reach out for help if for some reason school-based services are not enough or not present. Do reach out to your family doctor, your pediatrician, and for extra assistance.
Do you have an opinion on how safe it is for children to play outdoors with other children in their community, if parents want to start to do things like that?
I tend to encourage, Dr. Coffin, you want to talk about risk points? I love when you talk about risk points, but the idea of keeping your bubbles small and maybe identifying a couple families that share your risk level. I think a lot of families have kind of done this informally over the summer. And trying to identify, how to kind of, because there is a certain trade-off and balance on how you kind of appraise risk. Do you want to talk about, you had a sort of thinking about this?
Yeah. So I think that we can think about an activity as conferring increased risk, like going out and playing with a group of kids, but we also have to think about how risk accumulates over time. And so if once a week, you and two neighbor families who have a very similar approach and understand and are confident in each other's approaches and feel trusting, want to go and have a play date on the local park, that may be a risk that you want to take. Reminding your kids, keep your masks on. This is not a time to play, capture the flag and tackle everybody. But you don't go ahead and then follow that up by another play date with another two families, and then go and see to your family reunion with another 20 people. And so an occasional carefully selected activity with a small group of people is the way that we're all going to slowly grow our activities to move closer and closer back to what we want them to be. But this can't be an all or none, either we're at stay at home or we're at full throttle. And unfortunately, that's what we're seeing in a lot of these college outbreaks, and a lot of stuff that we're hearing about going on in bars and secret nightclubs reopening and stuff. We don't want that happening within our school districts and within the context of our schools.
Do you recommend screening for staff members and students prior to the opening of a return to any in-person learning?
If you mean screening by testing, the answer there is probably no, because a test, a negative test, only tells you one thing, which is what was that person's state of infectiousness at the moment the swab was being taken. It says nothing about what the person's infectiousness is going to be the next day. And so the logistics of getting an entire school or an entire faculty and staff tested typically means you have to allow people 1 to 2 weeks to get their test. That test that they get for coming back to school is essentially irrelevant to when people gather again at school. And so I think we need to rely on all of these other behaviors rather than lean back on a test and say, I was negative, full steam ahead.
Is it important that children change out of the clothes that they have been wearing upon their return home from the day at school?
I was just going to say, I was going to add, my wife and I are both pediatricians. Some of you in Delaware County probably know her, and because she works in Delaware County. But when we get home from work, we regularly change out of our clothes. We take a shower. I do think there's some routines. I think that we've talked about this, instructions for caregivers, having kids practice hygiene when they get home, wiping down the books when they get home, not being over obsessive about it, having them change out of their clothes. Maybe that's the time you do the shower. But I think, just a small change to the routine is probably all I would recommend in terms of what you're doing. And then potentially, if your child starts to have symptoms, remember that secondary attack rate. Have a little distance. There are times I've worked with families where an adolescent, let's say, is symptomatic. That adolescent may go to the room, parents may be delivering food. That kid may actually wear a mask in the common areas if they're watching TV downstairs. It's okay to do that because you can minimize, these attack rates, secondary attack rates of 15% are most likely under situations where you're doing none of that. Now imagine if you introduce a little masking and distancing when someone's sick in your household, you'll actually protect each other. So there's some slight alterations that I think people will do throughout the year as they work through some of these issues in their own household. Dr. Coffin, you have anything to add there?
Yeah, I just would add that since some of the early questions around, do I need to shower and change my clothes came out, we have learned that really transmission through clothes and hands is probably of lesser importance than respiratory droplets. So I do think that just like Dr. Rubin said, a focus on masking and cleaning hands are probably where I put my biggest emphasis. And think about just kind of the general care of the home and anything that you can do to heighten your child's awareness of how to keep themselves clean and safe is probably a good thing these days.
Okay. And we also have a few questions about athletics. Should high school athletes be tested for COVID with any frequency? And if athletes have tested positive, should they be evaluated by a cardiologist?
I'll tackle the first part. I'll let you talk about cardiology, Dr.
Yep.
Coffin. But the first part is, I think we actually distinguish in our recommendations between high contact, medium contact, and low contact sports. I don't think you need to be regularly testing the kids on the golf team or the tennis players who can distance while they're, and I'm not even sure you need to be testing those kids who are playing softball and baseball. If you are spreading them out in the dugout, they're wearing masks in the dugout, they're spaced out on the field. I've seen some nice alterations in softball and baseball where they've actually even moved bases apart so that the kids aren't standing, the first baseman's not even standing. It's the high contact sports that get my attention. Ice hockey, wrestling, football in particular. I know I'm missing a couple there, but for those athletes, if you're really going to get beyond individual drills, and I think most places in September should be doing individual drills because kids haven't really been exercising for a while. We've seen a number of elbow and shoulder injuries, and our sports medicine folks have been talking about using September as a time just to build up endurance again in individual drills. But to get from there to scrimmages in a high contact sport, I just think that there's been too much evidence that the only way to safely do that is with something called pooled testing, or pretty much daily testing before the kids get back on the field. And so I think it's extremely unsafe. And like I said, what worries me most, I talked about this window that's opened up, and we're definitely beyond the Labor Day effects here in terms of like returning vacationers. We're now into fall effects, and the fall effects are youth sports. They are college reopens to a greater extent than our K-12 reopenings. They're the large parties we're having on weekends, the large gatherings we're having, the football events, the Sunday events, and the holidays that will later come in fall. And we don't know how long this window is going to stay open. And I think if we can add those protections, if for those people who are really invested in that football season, high school football, I understand is a big part of our culture, right? It's got to be done right, or you can't do it because you're just going to confer too much risk, and you're going to see large outbreaks. I think that's pretty certain at this point.
Yeah, I think that's absolutely true. And I think that there a lot of evidence that the maximal protections can truly work for extended periods. But we have to remember there, our example from the NBA has people living in a 100% sequestered setting. There is no high school student who's going to be comporting themselves that way. And that, coupled with continuous testing, is the way the NBA has done that. I don't think we can even entertain anything that approximates that in real world.
And how about the cardiologist, if an athlete tests?
Oh, sure. As some people may know, there is a story that came out of Penn State reporting that a coach had identified a large proportion of his one of his teams, I believe it was a football team, who had what was referred to as myocarditis, or inflammation of the heart, after coronavirus infection. There's been a lot of attention on this question. And right now, what I understand is the American Heart Association, with a lot of input from pediatric cardiologists, including several from CHOP, has recently drafted guidelines about under what circumstances should a young athlete who has had a proven episode of coronavirus consider being evaluated by a cardiologist. And my understanding is that is only if the young athlete is participating in some of the highest levels of exertion, and that for people who are out, hitting a tennis ball with their buddy, playing some, doing basic drills, that should not be an issue.
Okay. And a final question about athletics: outdoor sports safer than indoor sports, or neither?
Absolutely. It's one of the ways we judge softball and baseball to be a little bit easier than basketball, which is another high, a lot of tracking, individual, close, heavy exertion, right? That's what makes basketball really challenging. I'd rather do basketball outside than indoors. If I'm going to do it, I'd probably want to minimize the amount of time the kids were in close proximity at high exertion. Basketball is one of those challenges because it's hard to wear a mask when you're playing basketball at that level of exertion. It's easier to wear a mask when you're playing volleyball. I'm not saying they don't exert themselves, they do, but it's not the same as when you're on, let's say, a soccer field or, et cetera. But those outdoor, the dispersion of those respiratory droplets is going to be much better outdoors. And so that is a fair statement, but still thinking about layering the different types of strategies depending on the moment of transmission, if you will.
And the last question in this category deals with the amount of screen time and the long-term effects that the amount of screen time can have, on the experiences that children are having now. Are there any guidelines that you recommend for a specific, amount of time at any elementary or secondary level, how it differs?
So this is the part where I fear I could be wading into instructional curriculum related questions, but I do have an opinion on that as a pediatrician, right? So I'm going to take that license. I swear that wasn't a plant, but that is the question I would have planted. And we have been saying to a lot of folks, throughout the area, be mindful of screen time. We wouldn't ask adults to go into work and spend 6 hours on screen in these virtual plans, and then 4 hours of homework on screen. That's an impossible task, even in the best of circumstances in terms of screen time. That I think that in some ways we need to create flexibility in our curriculum this year. I know we have the Pennsylvania curriculum, but to focus on trying to think about the amount of time we're asking kids to stay on screens, how we supplement that with maybe sort of worksheets that they can do at home, or maybe documentaries or something they can watch separate, but to leave time for unstructured time for kids this year. We talked about the mental health aspects of this epidemic. I think that, kids are best when they're left that unstructured time where they can be free to just let their minds wander a little bit. And and not necessarily on the Xbox, by the way, but to allow them to have some space to breathe a little bit, and just remember that as we kind of set up these curriculums and we go through our hybrid plans or our virtual plans, just to try to balance it out. And perfect is the enemy of good this year.
All right, thank you. Dr. Bertrando?
Thank you. Yeah, our next category is cleaning, disinfecting, sanitizing, and ventilation. So Dr. Coffin, I think this is your expertise. What are your recommendations for adequate air exchange? And are there indoor air filtration specifications that need to be implemented in a school to prevent the spread of COVID? And if so, what are they?
So, full disclosure, I am not an engineer. I have had to learn a bit about engineering for this and for other infections. And so what I can tell you is that one of the basic principles of infection prevention is that you can dilute risk by diluting the virus. And so by having relatively frequent air exchanges, you can essentially be diluting the virus through air circulation. There's not a magic number about what that number could or should be. I can share with you a reference number, which is that a hospital room has usually about 6 air exchanges an hour. And so that gives you kind of the ideal. A school, however, should not be considered a clinical environment and should not be saying, I need to get close to 6. However, airflow and air exchanges is one of the ways, but just one of the ways that we can reduce risk. In terms of filtration, what we've been recommending to building engineers is to make sure that their HVAC systems in each of the school buildings has been checked, is running well, that they have maximized to the extent possible with the existing system, the number of air exchanges, and that the filters are changed and in best working shape for the start of in-person instruction. Not necessary to pursue purchase of expensive systems such as HEPA filtration or UV light disinfection. There are many other strategies that would be much more effective and much more cost efficient.
There are a couple questions about keeping windows open in classrooms, and if there's not a window, are there any workarounds?
I think the concept of keeping a window open is just increasing airflow and air exchange. And while that's a great thing to do now, there's likely to come a time when nobody's going to want that window open. And hopefully that's going to be, coincide with the time when risk is going to be lower because virus is lower. The workaround is to increase airflow and air exchange without having the windows present or open. And so that's where working with the building engineer and perhaps specifically targeting if they can use dampers, et cetera, to maximize air exchanges in rooms that perhaps don't have some form of natural ventilation.
And I just want to illustrate that, you do the ventilation because it's an adjunctive, it can help. But if you're looking at marginal points you get, masking, distancing. You remember what I said? We said early on, 80 to 90, and then the hygiene. And so the ventilation adds some favorables onto there. But if you achieve those first two, they're far more important. You can be ventilating and have a classroom of 30 kids, and that is a far less ideal situation.
Then Dr. Rubin, just if you could extend that a little further out. So we received a question about the COVID cloud. Say a student has taken off a mask, or even a teacher for that matter, to take a quick break, sneezes or coughs. And we've all seen that news piece from China in the restaurant where the airborne particles travel through the system and then come back out into the restaurant. Would that look the same in a classroom if a similar situation like that occurred?
They would be fluorescent, those droplets now. And everyone would be staring at the ceiling. Now, the 6 feet and 15 minutes. I mean, obviously, like there's going to be breakthroughs, but if teacher is standing across the room and sneezes and there isn't a sustained exposure, and the other kids were wearing masks, it shouldn't happen, right? So a single event, it's not to say you can't have transmission. If you're right there in that kid's face and that kid sneezed a big heavy dose right on you, I suppose that could do it. But I think on average, there's always going to be the opportunity for a failure, in the system. But I think that through the multi-layer approach, the likelihood that single event would confer a lot of risk is going to be lower.
And just to chime in there, I think the other piece of that is as Dr. Rubin has reminded us, if it's 1 in 200 people might be at school on day one who's asymptomatic, we need to think about how likely is it that 1 in 200 person is going to be the person who is going to be sneezing when they take off their mask and is going to be immediately adjacent to another person and therefore at risk of inoculating them. And so again, another layer in that stack of things that keep people safe.
So in terms of getting away from ventilation a little bit, how about surfaces? How does the virus live on surfaces, and what does that mean for our custodial crews within our school buildings?
Sure. So experimental analysis has shown that the virus can live on surfaces. And some studies have shown that it can live for hours up to a day or two. What studies have not shown conclusively is that that's a common way of transmission. However, we all have agreed, whether it's in a healthcare setting or in a community setting, that frequent cleaning is likely a best practice because of our tendency to put our hands down and then put our hands up to our face and therefore risk inoculating ourselves. What this looks like for the people who are responsible for doing the cleaning, I think we need to educate them very well about what is risky and what is not. When a virus is present on a hard surface, it's not going to become airborne again as one uses the disinfectant to wipe it off. There's not a risk that it's going to be like dust and floating up in the air and make itself available to be inhaled. So I think that the appropriate protocols for doing cleaning would be damp cleaning, and with a disinfectant that can kill viruses, which are, I'm sure, all the disinfectants that are chosen by this school districts. And I think reminding that the housekeeping staff or the cleaners clean their hands after they've finished a room, in case they have managed to have some transfer onto their hands.
Thank you. Dr. Edelberg?
Thank you, Dr. Petrando. So my next question is around transportation. We've spent a lot of time this evening talking about social distancing of 6 feet and the recommendation of transportation, having all of our students masks, the bus driver mask, but allowing 2 to a seat. Is that really safe? Dr. Coffin, I know that you've been talking a lot about social distancing. If you would like to.
Yeah. I do not like the concept of 2 to a seat. And I think that does fly in the face of what we're trying to encourage people to do, of thinking about layering strategies. I suspect there are many kids that are on a bus for longer than 15 minutes. And so it does set kids up to be at higher risk during a moment of transportation. There have been a lot of school districts who have attempted to maximize the safety while still providing good transportation options for their students and block out every other seat. One aisle, one window, one aisle, one window. And that seems like a good strategy. But I think in an ideal world, we would have more options for kids to get to school outside of the school bus while we still have significant amounts of virus in our community.
And I would agree with that. I think that's a potential hole. I think a lot of parents are going to vote with their own feet. I would, I think I've talked to a lot of schools about parent pickup line being an important, really, not so much for disease transmission, just the inevitability that a lot of parents are going to be driving their kids to school. I imagine Delaware County is one of those areas. Philly is harder because so many kids ride public transportation to school. But getting kids in and out of the building, that's a big moment of transmission, and that's going to be part of like strengthening these protocols. And hopefully there'll be a reduction enough between those parents who choose to continue their kids virtually and those who are driving their kids to school, that we can de-densify those buses. But I think that would be an area that we would recommend additional considerations around busing if you can't meet those distancing rules.
Thank you. And then we had a fair amount of questions around metrics. And so several of the questions stemmed up, what does infectious rates look like for our children, our younger children and our children of high school age? And also, have we seen a lot of hospitalizations of children? And how about at CHOP? Are we seeing a lot of children that need to be hospitalized due to COVID?
So I'll start here, and like Dr. Coffin, in the spring, the part that gives us a little bit of concern is we haven't seen a lot of kids get sick, but it was also during a time that we isolated our kids pretty quickly in the spring. We obviously saw this very, very severe inflammatory syndrome that is still rare, and would emphasize is similar to something we call Kawasaki's disease, but a little bit different from there, but very significant, with a lot of heart dysfunction, very sick kids in the intensive care unit, but it was extremely rare. But that was during a time when we had removed all the kids from the schools, and without much protection. It said a lot of that was the early risk while they were still in school, and it was kind of conferred over the next few weeks. Now, as we go back to school, one of the things we're watching, and as kids start to mix again, is we're seeing infection rates go up in the kids. They still are kind of tending to be mild, particularly in our younger kids. Just to show you, the adolescent hospitalization rate, I think, is likely still at about a 1 in 1,000 or 2 in 1,000. It's really, really low. But one of the questions we'll be asking: will we see more pneumonia? Will we see more of this inflammatory syndrome, as we just have so many kids mixing in sports leagues, et cetera? And what we talked about is, like, as a comparator, is 150 kids died of the flu last year. We're now up to about 120 to 130 kids who've died of COVID. And so it's no longer fair to say this is less severe than the flu. It may not be more severe in terms of the sort of those rare exceptions, but we still have a winter season to get through here. And so I think we have to be careful. And then just remember that while the kids may not be hospitalized, we do have emerging evidence of their ability to transmit this virus. And so it does confer risk to their families, to their grandparents, to the teachers in schools if we don't do this right. I don't spend a lot of time worrying about my kids, but I do worry about outbreaks originating from schools if we don't do this right.
Thank you. We just talked a little bit about the rate of infection for children. What advice would you give parents who has a child with special needs that also has layered on that some significant medical issues? and they're trying to really weigh that risk of, do I send my child back for in-person instruction, or do I look at an alternative? What type of metrics or conversations would you impart with these families?
Well, so far, here's the good news, is the benefit that we think a lot of the benefit to kids being at less risk of infection has to do with these ACE receptors that actually mature in the adult lungs as people get older and the immune response, et cetera. But a child with special healthcare needs has that same advantage. We've already talked about asthma may even have a special advantage. But the interesting thing here is we have not seen a lot of cancer patients getting sick. We have not seen our children with cerebral palsy flooding the hospital. We've not seen our kids with diabetes the way the adults with diabetes flooding the hospital. All right. So, I see very few exceptions in which I think there is a child with special healthcare needs that would be at increased risk. And I don't think we should be isolating them more than we do other kids. If I thought the evidence was there, we would say it, but there's a select group of kids that I do worry about. It's a very small group of kids with neuromuscular disorders like Duchenne's muscular dystrophy. It would be kids with airway compromise or severely compromised lungs, right? That we probably wouldn't take the same risk on just because of the potential for, the challenges they have with just regular respiratory infections as well too. And so those tend to be a minority, a small, rare group of children. Some of them may be often wheelchair dependent. And for those kids, I think that, as we run our special ed classrooms, if they come in, we've actually advised for extra protections in those rooms. But we also said to the staff, those families are likely protecting those kids, and those kids are not mixing to the same degree that other kids are. In fact, they're more at risk from the staff than the staff being at risk from them when they're not wearing their mask. And so I do think those require very thoughtful individual decisions. And I think that one behooves each family to kind of make that choice, understanding what the true risk is in each of those situations.
Thank you. And we're getting towards the end of our program. So I'll start with Dr. Rubin for some closing remarks, and then Dr. Coffin. Dr. Rubin?
Yeah, look, I think there's just a lot of information flowing out there. Some of it true, not true. There's a lot of anxiety in the air as we try to do this. But since March, our folks at CHOP, Dr. Coffin, myself, and many of our colleagues have been following this extremely closely. And we're also following, we also recognize, people have asked us, well, you said back in the summer you did this and now you're changing. The reality is this is a new novel coronavirus. And we are constantly looking at data to challenge our assumptions. And what we have seen, the fair reading of the evidence to date, is that there is a path to safely reopening our schools and getting kids back and balancing the risks, the socio-emotional risks that the kids have had through their isolation, the needs to educate our kids. And it's through this multi-layered approach that combines incidents with a whole bunch of strategies in the school day so that we can keep going. But it also places a lot of responsibility, not just on the individual school district, but of the communities themselves into how they manage the moments of transmission through the fall. A window has opened up. That window could be 6-8 weeks before we really get into wintertime transmission. We have seen areas around the world that blew right through their winter without any transmission while kids were in school because they committed to the strategies that we talked about. But we're also seeing areas of our country right now that may not see a reprieve for more than a week or two if people continue to load into the bars, they continue to have big parties and kind of blow off the basics, easy things like distancing and wearing a mask in public locations or in school or hanging out in smaller gatherings. So we have a lot of uncertainty about what the length of this window is right now. We also have some uncertainty about what the amplitude of this next wave will be if it comes here in the winter. And a lot of it is riding on how we kind of create that compact together to manage risk. And we can't always control what everyone in the community does, but some of the advice we gave today, some of the advice about identifying a couple families so that you can balance the risks of having your kids, having some kids to play with, but not overdoing it, of really encouraging and actually as parents really demonstrating for the kids the importance of wearing those masks in those public locations. And a lot of parents have worked extremely hard to reinforce the sensible use, not the I wear my mask everywhere, including when I'm standing in a park with no one in it type of mask wearing, right? The sensible use of masks in public locations. And if we do that, I honestly believe, and I think Dr. Coffin does as well, we can have a really healthy and productive school year and build upon the successes that we're having. But it's really, we're watching this week to week, and we'll just have to see. And if we need to pivot back to distance learning, if we have to pivot when break, we will. And we'll continue to follow, stay in touch with your school districts, continue to put out information to let you know our latest read on the situation, and hopefully help you make better decisions on behalf of your families and your schools and your teachers so that you guys can stay safe, and we wish you well.
Thank you. Dr. Coffin?
I guess what I'll do is start with the one thing I worry about, and then end with what I think is very encouraging. The thing I worry about most is fatigue. And I think we are now, we've crossed the 6-month mark, and we're still doing this, and we don't see an end. And I think it's really hard. And I find myself getting a bit fatigued of talking about this, of worrying about this, of trying to be more creative in helping others negotiate. But I think we as educators, as parents, as role models, really need to figure out a way to shake our head, shake the cloud of fatigue and concern out of our head, and remember, we know how to do this. We have been doing it, and we have been doing it actually quite successfully. Our area had a lot of virus in it in spring, and we drove that number way down. And through our kind of really deep commitment to personal and family activities, as well as to others in our community, I think we can keep the rate of virus down low. But it does take energy and a real persistent focus on adhering to all of these practices.
Thank
So
you.
I really hope everybody has a great school year. And I know it's going to be one of a kind, but I think and hope it can be a productive one.
Thank you. And this really is a community effort and a partnership between schools, home. And it's really important what the takeaway is, that screening and that we're in this together. If you're not feeling well, stay home. And that goes for our children and our staff, because that's probably our first defense in helping make this a safer year. Thank you, Dr. Coffin. Thank you, Dr. Rubin. Every time we have a webinar or every time we meet, we walk away with more knowledge, and you're helping us all be successful. For the audience, I hope you found this a productive webinar. You will be getting an email through Constant Contact that will let you know when it will be available on YouTube. So if you would like to view it again, because there's been a lot of information provided. Thank you for being with us tonight. Thank you, Dr. Rushi, Dr. Bertrando, for moderating the session tonight. And again, Dr. Rubin, Dr. Coffin, thank you for continuing to give us your expertise and share it with our community. Have a wonderful evening. Goodbye.
Bye all.